Hello, I'm Deborah Chieli, a nationally board certified nurse practitioner with specialty certification in lifestyle medicine.
And I'm Susie Spell, a nationally board certified nurse practitioner, also certified in lifestyle medicine.
The following interview was part of a series that informed our presentation at the 2023 Annual Conference of the American College of Lifestyle Medicine, ACLM, titled Nurses in Action, How Nurses Operationalize Lifestyle Medicine in Modern Settings, and You Can Too.
In this series, nurses from diverse backgrounds and practice settings and their champions tell their personal and professional stories about discovering lifestyle medicine and how they're implementing it across a wide range of settings.
Nurses are the largest health profession in the United States and globally, and have been voted the most trusted profession here in the U.S. for over 20 years. Learning about and incorporating the pillars of lifestyle medicine fosters full scope of practice and the ability to answer the call to lead by the National Academy of Medicine with their report, Future of Nursing 2020 to 2030, Charting a Path to Achieve Health Equity.
We hope these stories of success will inspire conversation and drive creative solutions to better address inequities in healthcare. Continued growth of nursing expertise in lifestyle medicine will expedite our nation's ability to address the public health emergency of chronic lifestyle diseases we currently face.
The power of nurses to create innovative solutions when combined with the practice of lifestyle medicine allows nurses to express their full potential while simultaneously addressing the salient issues of health equity, the epidemic of chronic disease, and the provision of truly patient-centered whole-person care.
When nurses are empowered to lead with an interdisciplinary and multi-sector practice, they answer the call of the National Academy of Medicine to dissolve barriers to care and improve health for themselves, the nation, and every global citizen. Enjoy the interview. Today, we are really excited because we have Dr. Josie Bidewell with us. She is a doctorally prepared nurse practitioner who's a lifestyle medicine clinician, and she is clinical director of the Department of Preventative Medicine at the University of Mississippi Medical Center, UMMC. She's also an educator, and she teaches within the School of Medicine and the School of Population Health. And she has also precepted students in all 7 of the health professional schools. So that is a lot. She's done a lot of educating. Dr. Bidewell obtained her BSN in 2004, her MSN in 2006, and her DNP, which is Doctorate of Nursing Practice, in 2013, all from University of Mississippi. So obviously she loves her alma mater. Dr. Bidewell has been a trailblazer for nurses, truly. She's transforming her passion for lifestyle medicine into clinical practice and sharing that with patients as well as the next generation of healthcare professionals. She's a board-certified diplomate of the American College of Lifestyle Medicine, ACLM, and was awarded the prestigious status of fellow within the college. And if you're not familiar with what it means to be a fellow of a professional organization, I'm going to take just a second to tell you what that means. It really means that individual has demonstrated the highest standard of professional development and contribution to that field. Any fellow of the ACLM has contributed outstanding achievement in the field of lifestyle medicine and has shown unwavering and exceptional dedication to advancing the college's mission. And I want to take a minute just to highlight a few of the reasons Dr. Bidewell was awarded this certification. She's been lead author of the Southern Remedy Healthy Living Physical Activity and Curriculum for both adults and children, which was a collaborative effort to address obesity in Mississippi. She is host of Southern Remedy Healthy and Fit on Mississippi Public Broadcast Think Radio. She's a community health advocate, master trainer, providing nutrition, physical activity, and healthy living training to laypersons as well as health professional students. She established the Cook Right Live Teaching Kitchen in collaboration with a physician colleague, Dr. Alan Penman, which was funded by a grant from the Bauer Foundation. She's a fitness instructor, and she used to be on the medical advisory committee for the wellness centers, but now they're about to open an Exercise is Medicine collaborative within their lifestyle medicine clinic, which is on site. And I remember her presenting to the ACLM RN APRN group about how to go to the dollar store or something like that and really be able to eat a healthy plant-based diet on a very limited budget. So she is bringing this information to everyone that she interacts with. And as if all of that wasn't enough, she was inducted into the UMMC Nursing Hall of Fame in May of 2021. So clearly we have a lifestyle medicine nursing celebrity with us today. So thank you, Dr. Bidewell, for being with us and sharing this time with us.
Thank you for having me, and thank you for that wonderful introduction. It really means a lot, and I couldn't be more excited to be here talking to my favorite partners in healthcare.
That's right. Nurses. We love them too. So what I'd like you to start with, I know I said a lot, but I really want you to fill in the gaps and tell us about your current role of what you're doing right now in nursing, how it may differ from what we think of traditionally, and how you discovered lifestyle medicine that got you started.
Yeah, absolutely. So my background as a nurse practitioner has been varied, which I feel like a lot of nurse practitioners go down that track, but it's always had a wellness and a health promotion focus to it. I've done internal medicine and pediatrics has often been my great love. It's what I did as bedside nursing, and actually became a school-based nurse practitioner for many years, which worked a lot on nutrition, physical activity. That's where I did my doctoral project work as well, was in school children and working on improving their nutrition and their physical activity knowledge and self-efficacy. And so all of that was before I found lifestyle medicine and before I found the American College of Lifestyle Medicine. Fast forward a little bit, and I was made the clinical director of a clinic called Unicare, which was our family practice clinic for the School of Nursing here at the medical center. So it was staffed completely by NP faculty, and it also served as the main clinical site for our NP students, as well as all of our undergraduate clinical students. And that's where I spent a good chunk of my time doing primary care. And that's really where I just had to stop and say, what are we doing? Are we making people better? Or just watching them slowly get worse over years? And not for lack of trying on their part and our part, but you can only do so much once end organ damage is there, and so I stepped back and said, I need to re-envision the way I approach a visit with patients and how I speak to other healthcare providers about how we should be treating patients, and that we've got to be really proactive. And that is above and beyond making sure they've had their mammogram and their colonoscopy and all of their vaccines. But we've got to pick up on the fact that, their blood pressure was 125 over 80. That's too high for a systolic pressure in a 40-year-old. By the time they're 70, it's going to be 160 systolic. So we have to be really proactive in these things that are not big, shiny red flags going, oh, look, I have hypertension or I have severely uncontrolled diabetes. And so I started working with the emergency department in trying to capture those patients that were coming into the emergency room for clinic issues and just getting a 1-month supply of blood pressure medicine and not getting a follow-up because they had unreliable transportation or they didn't have health insurance and those kinds of things. And we really worked on a partnership there where if you came in the ER, you didn't have a primary care provider, and you didn't have insurance, we negotiated a doable pay range to get those people in clinic and take care of them that way. And that worked very well. But again, it wasn't proactive enough. I needed to see them before all of these things started to happen. And about that time, our Department of Preventive Medicine was revitalized. So we had that department in the past, but it was very much a research-based department. It was not a clinical department. And then it closed down. And then in 2015, they reopened it and wanted it very much to be a clinical department, brought in a physician that actually trained here in medical school, but was practicing preventive medicine in South Carolina. So they brought him back to get this started. And of course, a clinical department in a school of medicine usually also has a residency attached to it. So to start a preventive medicine residency, and you got to have a clinic for those residents to rotate in. And we served on some wellness boards together across campus. And if you spend more than 5 minutes with me, you'll know I'm very opinionated about wellness and what we are missing out on and the gaps that we have. And apparently he enjoyed my frankness. So he called me up and asked if I would help start a clinic for the Department of Preventive Medicine. And that's really when I started going, okay, what is this going to look like? What are we going to do? And that's when I found lifestyle medicine. And I said, I will. If we do it like this, this is how it needs to be done. And they started to work part-time for preventive medicine, still maintaining regular role in the School of Nursing. And we opened Lifestyle Medicine Clinic September 2017. And by mid 2018, I had added so many days of clinic, I couldn't keep up. And I said, I have to make a decision on where I feel like I can make the most impact in not only individual patients, but in training healthcare providers to do this. And that was a scary decision to step out from a school of nursing where they were all my people, right? They were all nurses and we all spoke the same language, to moving into a school of medicine where I was the only nurse. And, no other nurses on this department faculty, very few nurse practitioners with any level of faculty within the School of Medicine and do that. And it's really been eye-opening to be able to see what people don't necessarily understand about what nurses do and what we can bring to the table. But what's really exciting is the fact that I do get to train residents. They each spend 6 months with me in clinic. That's a long time for them to spend with me in clinic. Is the mutual appreciation that we both have for what we each bring to the table in terms of how we interact with patients. And there are things that they're always going to do better than me. And there are things that I can teach them to do as well. And I think it's really helping to break down. Sometimes there's friction and tension between different disciplines. I really think this is a way we break that down where we learn from each other.
That's amazing. That sounds like an amazing opportunity and journey that you've been on. So,
it has been a journey. It has.
And I have a number of questions, as does Deborah, I know, but a couple things I heard you say, which I assume are probably key elements in your ability to be successful with this clinic, is the partnerships and collaboration, maybe that you had with the ER, and then maybe others as well. So what do you think were some key elements or essential things that had to be in place to make this a success?
I've been very lucky in the fact when you read my bio, you mentioned I got my bachelor's, my master's, my doctorate, all from here. I've been here forever. This past January marked 20 years that I have been here at the medical center in some form or fashion, whether it be student or employee. And so during that time, I've made a lot of connections and have met a lot of people. And I try and always do the right thing for the person in front of me. So if someone from family medicine calls and needs something, I'm going to try and get that done for them. Even if it's not with my clinic, I'm going to try and call orthopedics and get that done. And that really was very beneficial in the beginning because I was able to draw on those connections and be like, hey, this is a new endeavor that we're starting. This is what it looks like. Can I come talk to your group? Can I come give a grand rounds to internal medicine about what lifestyle medicine is? How can we partner with orthopedics to help them take care of their patients? What is your biggest need that you have that you feel like you're not able to currently address in clinic? And latch onto those. What we purposely did not want to do was be seen as another primary care clinic. Within an academic medical center, we've got a very robust family medicine center or department, a very robust internal medicine, and then gynecology and geriatrics, all that are providing primary care. So trying to duplicate that, and it's just redundant. Like we didn't need more primary care providers. We needed more people practicing lifestyle medicine because the primary care providers knew the gap, right? Like they knew that they needed to be talking to their patients about diet and exercise and sleep and stress and all these things. But it's very hard in the 10 to 15 minute, if you're lucky, visit time that you get to do primary care in someone with the sheer number of comorbidities that we have. Mississippi is often number one in the things that we don't necessarily want to be number one in. And so we have lots of heart disease, lots of diabetes, lots of chronic kidney disease, and those types of things. And so leveraging partnerships that I knew and then going in with a plan. Not just, I'm going to talk to your patients about nutrition. When we went to orthopedics, it was, tell me what you need. And the response was, we have all these patients who need joint replacements and they're high risk surgical candidates for a variety of reasons. What can you do about that? We went to the literature and pulled what are modifiable risk factors for total joints. And it's a BMI over a certain amount. It's an albumin under a certain amount. It's being anemic. It's smoking. It's poor dental health. All these things that can be modified that they simply don't have the time to do in an orthopedic visit, nor probably the comfort level to discuss all of those things. So why not partner together to get that done, right? So when I speak to orthopedics, I speak to them very differently than I speak to nephrology, right? Because I'm not running a joint program for nephrology. But when we talk with orthopedics, this is what I can specifically do for you to help you take better care of your patients, not to take your patients, but how can I help you get the best outcomes for your post-op patients, right? So that you don't have revisions and you don't have post-op infections and all of those things. Where that's different than nephrology, where we talk to them and say, what's going on with you guys? And it may be that patients can't get listed on the transplant list because, again, they fall outside of the weight requirement to be on the transplant list. And those folks to us, we will work on getting them ready to be on the transplant list for whatever, whether it's smoking, whether it's weight, whatever it is. And that way they can continue to do what they were trained to do very well. And I can focus on the things that I'm trained to do very well. And the only person that wins is everybody. Like I'm happy, they're happy, and the patient gets better, which is, I don't care what specialty you're in, or whether you're a physician or a nurse or a PT or an OT or a dietitian or a psychologist, we all did this at some point. We all signed up for this to make people better. And that's what we have to figure out to do. And that not everybody has to do it all by themselves. And I think that's really refreshing for folks as well, to realize that you don't have to be the expert in every single part of every bit of medicine. We're all here to support that patient.
I love that. That was such a great explanation. And I heard a few things that I'll just recap real quick, which was you drew on your connections you already had. And 3 things I wrote down was building relationships and partnerships even above what you had already had, which moved forward the clinic, and that you were curious and asked about what the need was that needed to be filled. And then you were being of service. Yeah. How can we help you? And so once you knew those things, you could craft a plan.
Absolutely.
So having a plan.
A very specific plan for each one of those areas. And that's really, they want these things. Family medicine. We're going to launch in 2 weeks group visits for hypertension because that's what they felt like they needed, right? We already have a diabetes prevention program that we're funneling our pre-diabetics into, but in particular, nutrition and self-care behaviors around hypertension, taking your medicines, knowing how to check your blood pressure correctly, keeping your doctor's appointments, what is salt, what is potassium, how these things impact your life. They were needing this. And so we've built that with our dietitian. So I'm not going to have to be involved in that at all. It's going to be the student that is working with me on this particular project. So it'll actually be her doctoral project. We're calling it Lifestyle Approaches to Managing Hypertension.
Oh, nice. Really nice. So it sounds to me like everybody wins, right? And even
everybody wins.
Mm-hmm. And what you set up to be successful in the beginning is that you guys created, or I'm guessing had some strategy calls or whatever to really hone in on what this clinic identity was going to be. And then also, did you recruit other people in different fields of medicine to help you further this along? Did they have to go get training? How did that happen?
So when we first started, it was just me and no clinic, nothing. Just me, and I had a sweet little plate, divider plate, and some exercise resistance bands and some cool handouts. And that's all I had. And we actually met with family medicine and asked very nicely if I could have some space in family medicine, that I had nothing to offer other than I would be willing to help their patients any way that I could. Could I have a borrowed exam room, basically? Because whenever you're starting something from scratch, the first question is, what is that? Especially with something that was, what's lifestyle medicine? They were like, what is that? And then it was, will people come to that? People want that service. And then the second piece was, will you get paid to do it? And so all of those were questions on the front end that you have to have at least proof of concept before you can ask for clinic space or more staff or any of these different kinds of things. And so family medicine very graciously said, yes, you can have one exam room half a day a week. And so that is what we launched with. And it was Friday afternoon, which is not the most coveted of all clinic spots. But my take on that was, if I can make this successful on a Friday afternoon, then it is going to work just fine. And so we opened the last Friday of September in 2017. And so just that little half day a week, we did that. And I think I had 42 visits in that last kind of quarter of 2017. And then it exploded. And the way it exploded is because where I was sitting in family medicine, the attending room was full. So I sat with the residents and they thought all my stuff looked cool. They like my plates and all my stuff. And they would say, I have somebody with diabetes. What are you doing? And I said, I got a few minutes because I didn't have any patients yet. I'm like, why don't we just go down to your room together and I'll see if there's something that I can help with. And so they started to see lifestyle medicine in action and how the patients were eager for that information. And they said, can we just refer to you? Absolutely, you can. And taking that back one step, when we originally rolled out lifestyle medicine, we envisioned it as a wellness clinic almost. Our state benefits, so we're a state hospital or a state funded hospital. Our state insurance that all of our employees have allows for 2 wellness visits a year. Most people don't use that second wellness visit. They go to the gynecologist and that's about it, or once. So we marketed initially to be Wellness Plus is what we were calling it. So use your second wellness visit with us in lifestyle medicine. And we did have wellness visits that came through, but what really took off is when the residents started seeing how it could translate into their problem-focused visits. And they started referring. And I got so full that I couldn't see my follow-ups. And so everything has evolved very organically, but very intentionally. So I would not take more new patients if I could not see my follow-ups in a timely fashion, because I know that multiple frequent points of contact are what it takes for behavior change to be sustainable. So I said, I think I'm going to need some more space and some more time. And another clinic gave me another exam room half a day a week. And that one filled up. And then another clinic gave me another half day a week, and that one filled up. And that's when I said, you know what, guys, I think I've proven that, yes, people understand what lifestyle medicine is. Yes, patients will come to it. And yes, I will get paid to do it. So can I have my own space now? And yes, so it made my heart explode the first time I walked in. A 3 exam room clinic and a group room with a beautiful sign that said lifestyle medicine, like a real sign, not something I printed out and hung up, but a beautiful metal sign. And then COVID hit. And so we had this beautiful clinic and not a single patient in it, but we were able to completely flip to telehealth. And we were one of the only service lines on campus that increased their clinic volume during COVID because it's translated and delivered so beautifully across telehealth. And now we're a hybrid. We're about 50% telehealth still and 50% in person. And we've outgrown our clinic. So you asked about other team members. One of those clinics that I mentioned that gave me a half a day exam room was GI. And so again, they gave me that space because of the synergy that can happen between lifestyle medicine and GI. So I was seeing their fatty liver patients for weight loss. And there was a nurse practitioner there who, again, walked by the little room they gave me. And I was lucky in the fact that nobody else used this room. It was a very small little room, but I had it all set up with all my stuff. And she walked by and she just looked around the corner. And she did that a couple of times. And I said, hey, my big old self, what you need? And she said, what are you doing in here? And I told her, and she said, I have administrative hours on Friday mornings. Can I come watch? You sure can. So she started to shadow and fell in love with it and ultimately moved over to us. And we mentored her in the delivery of lifestyle medicine by telehealth, because this was all right when COVID happened. So I precepted her through telehealth, and she sat for her boards, not last year, but the year before, and is a board certified diplomat as well. And now we have her, myself, a dietitian, and a medical office assistant, and adding in an exercise physiologist very soon. So
I love that. What a great story. And it seems like you were present there and people were curious and you just capitalized on that curiosity.
Oh, yeah. Let me tell you about it. You got a few minutes?
Right.
Sit down.
That's amazing. Can you tell us a little bit about your role as educator, as educating? We know that you're also working with residents. We're trying to really hone in on some of the nursing, and in particular, how you can navigate the diet and how nurses, RNs, or NPs can help with that piece of it, because there seems to be some overlap and who's doing what, who's staying in their lane or not staying in their lane. Can you talk to us about that?
Yeah, absolutely. As I mentioned, I started out in the School of Nursing, teaching in the undergraduate program primarily. And at the junior level. So I had the brand new nursing students, and they were a wonderful group to teach and get to take to clinical and all those things. And I have missed that actually now in my role in the School of Medicine. I am the lead faculty for our lifestyle medicine residency curriculum. So I teach those residents in the LMRC. But we have also developed opportunities for other students to come in with us. So just this past spring, we actually were approached by the School of Nursing because of the BSN Essentials that speak specifically to community and health promotion and disease prevention. And they identified that as at least in terms of clinical application, gap for them to have somewhere for students to be. And so all of those students now rotate with us in lifestyle medicine so that they get the opportunity to see what that looks like, what a good social determinants of health evaluation looks like, and then how you compile a set of resources for patients, right? I'm not going to solve food insecurity within the four walls of my clinic, but how do we partner with community agencies so that I can write a prescription for people to go get emergency food, right? And those types of things. And one of the things that I really have focused in on the nursing students this time is taking them out into the communities. One of their rotations, we go to a local organization it's a food pantry, clothing pantry, that kind of stuff. And one day we just hung up clothes, and that the organization then sells and uses money to buy things for the participants. And because I think the best way you learn about the patients that you're going to serve is to see what they interact with on a daily life, because it is often very different than the home that you go to at the end of the day, or the way that you access food or laundry or any of these different kinds of things. And so we've purposely built those things into there so that those nursing students can start to have those conversations with patients at discharge in the hospital. Most new grads go to the bedside when they graduate. And you should. It's wonderful. You learn a lot about life at the bedside of a patient, regardless of what specialty you choose. But there are, even in your long shifts, right? Even your 13-hour shifts, the amount of time you spend with an individual patient is rather brief. We spend 10 to 30 minute chunks of time around on that patient. And that's all we see. And we think about, oh, I can bring them this food tray that has a, heart healthy diet on it, which I would argue it's probably not a heart healthy diet, but we bring it to them. So we're controlling the food that they're getting while they're here, right? PT and OT comes and gets them up out of the bed and walks them and does all of these things. Social work may come and arrange for their medicines to be ready at discharge for them to get. But those people leave. And what are they leaving and going back into? And that's what we have. That's the opportunity that bedside nurses have to think about those modifiable determinants of health that we really can address on. Even if we don't feel ready to talk about what good nutrition is, we can talk about, do you have access to food? Right? Because it doesn't matter how good your nutrition knowledge is. If your patient can't eat, it's worthless. So the first step is feeding people and making sure that people are fed. And then you can take it a step further. So with these community organizations that I work with, we write recipes for them. They'll say, this is our box of kind of shelf stable food that we have that we're going to give out to people. I'm going to take that and write plant-based recipes off of that, right? Because it's rice and beans and pasta and all this kind of stuff. I'm going to write a recipe on how you make that a complete plant-based meal. And those are the things that patients need when they're leaving the hospital, because in the totality of their life, they spend a very short percentage of time with a healthcare provider. And we have to equip them with the things that matter to them, right? While I may want you to have 5 to 9 servings of fruits and vegetables a day, you may only get one. You may get none right now. And what's important to you is just not being hungry. And when we meet people where they are like that, then we start to build that trust. So when they come to clinic next time, they'll say, I really appreciated that support. Can you tell me how to use these ingredients more? And that's how we start to make change. Same deal with PT and OT and those kinds of things. We rehab them when they're in the hospital, and then we just send them out. And we're like, okay, do some walking. And do they live in a place that's safe to walk? Right? Do they live upstairs and they're having difficulty going down the stairs to get out and walk? Right? Is it Mississippi? Because it's 102 degrees right now. And I sure don't want my heart failure patient out there going down the sidewalk in this heat. So knowing where your patient is going to go when they leave the hospital is really the opportunity to start that lifestyle conversation for bedside nurses.
That's amazing. Thank you for all that rich information that you just provided. I do want to ask you specifically, what kind of social determinant of health evaluation do you do? Is that done in your clinic? That's one.
It is.
And then the other thing is, do you collaborate at all with nurses already inpatient to bring any of this to them?
We will frequently do talks and things. I would love to, what I am hoping for. It makes my chair a little nervous when I talk about it, but I've probably made him nervous with every single thing I've said we're going to do, is to move into inpatient consults and really target that population. When you're in an outpatient service line, one of the ways you offset your no-show rate is you double book patients. We don't do that in lifestyle medicine, right? Because lifestyle medicine visits are long and I will not be rushed. Like, you have me for this amount of time and we're going to do it together. And so in looking for a way to, capitalize on pockets of time that are available within the clinical service line, inpatient consults is a no-brainer to me. You are getting patients, they're here, right? They can't no-show on you unless they are in the bathroom. And so that's a way to get them. And then it's also usually when people are at peak motivation because they've just had a major life event, right? They've either had a cardiac event or a new onset diabetes or an amputation or renal disease, something that is prompting them to want to make a change. What we then have to be able to do is meet that need, right? And so training other providers to be able to deliver this kind of content is so important. And I'm hopeful if we're able to get that up and going, that will create a richer relationship with the discharge nurses. At least in our hospital system, we often have nurses that kind of serve mainly as the discharge nurse for that day, or those types of things, and give them the tools that they need to be able to do this. The second piece is getting the word out to all healthcare providers about what good nutrition is. That's the one I see as the biggest barrier, is everybody has an opinion on nutrition. And it's often what has worked for them. And when I'm talking on the radio and I'm giving recommendations for nutrition, I'm like, guys, there's always going to be somebody who has found success doing something extreme, right? Whether it be the ketogenic diet or whether it be significant intermittent fasting or any of these different dietary plans, someone's always going to have success on it. But what is successful when applied at the population level? And it's very clear that is a plant predominant diet. We have to eat more plants if we want to keep our heart and our kidneys and our liver in good shape. And so breaking down that kind of misconception about what good nutrition is and that fruit has too much sugar. I saw a note this week, some sweet provider put in there, stay away from fruit. And I was like, oh, I'm going to take you to coffee. Like we're going to have a meeting because I want to talk to you about why it doesn't, like why it makes good science sense that it does. But when you actually get down to the fundamentals of it, it doesn't. And you have to be really comfortable in your knowledge, and because there's always going to be people who are going to push back at you on that. And that's one thing that I think ACLM does a really good job of in preparing you for boards is making sure the literature. What does the lifestyle heart trial show? What does the broad study show? What do all of these things show so that when somebody comes back to you with fruit has too much sugar, you can go, actually, this is what the science says, and say the name of the study, right? Because once docs and nurse practitioners and PAs and hear the science, the really good science, not the one-off studies, I don't think there will be territory where that bedside nurse shouldn't be talking to a patient about diet. Because right now we're afraid they're going to tell them something weird. But if we're all on the same page of what good nutrition is, then it shouldn't matter who is delivering that content because we're all saying the same thing. And that starts with lifestyle medicine being integrated into all levels of health profession education.
I love that. Yes. We have a little while to go for that, but
we do. Well, I keep nibbling away at it. I'm about to train 80 medical students to be health coaches.
Okay.
They are eager and excited about plant-based nutrition.
Yeah. And one of the things that you didn't touch on, but that it just comes to my mind is that when I started learning this information, it like reinvigorated my passion for this profession at a time when I was really burnt out. And I'm like, actually,
I was going to go home before I found lifestyle medicine. I had that conversation with my husband. I was like, I think I'm done. I don't think I can do this anymore. I'm just burning myself to death. And I don't feel like I'm moving the needle, not even for the person in front of me, right? There's the thought of how do we move the needle from a population standpoint? But then there's how do I look at this person that's sitting in front of me that is trusting me with their life, or it's trusting me with their child or their spouse or there's somebody, and I don't have anything else to offer them other than let's increase this medicine or let's go see another specialist. And I just couldn't do it anymore. I got to the point where I'd wake up in the morning and I just felt nauseous. I was like, I don't want to go. Don't make me go. And now It's still hard to see population level change move, but to see that person in front of you come off of their medications is the single best day that you can have. And we actually got a button made. It's a gold button that plays celebration music. And so when they reverse a chronic condition, they get to bang it. Like when you ring the bell when you're done with chemo. So we get to do those things. Even if we don't reverse the disease, if we drop a medicine, we're hitting that button, right? We're really celebrating those things. And we think about lifestyle medicine healing the patient, but for me, it healed my provider soul because I just couldn't keep doing it the way it was going before.
No, I feel that. I know about that. I do want to ask you a question about the long visits that you commented on. So the long visits, how long are they? How do you get reimbursed? And how are you using, if you are at all, any RNs in the clinic through lifestyle medicine or coaches, or specifically we're interested in NPs, but also how RNs are influencing this as well?
Visit times have evolved. When it first started, everybody was a 40-minute visit because that was the standard lengthy time slot that we had built into our EHR. And it worked okay. And then I started getting busier, and then we started doing 40-minute for new patient, 20-minute for follow-up, and I didn't like it. And I'm very blessed in the fact that our department listens to my concerns. And I'm very adamant in the fact that I'm not here to generate an RVU number. I'm here for clinical outcomes, right? And clinical outcomes go down when visit length was going down for us. And so we worked very strategically on how we capitalize on that. And ultimately what we found was, do I need to be physically present for all of that visit, or can I bring in team members to help with that? And we ran some break-even analysis on the cost of a dietitian, and that's actually how I got the dietitian. So we calculated because we time-based bill, so that kind of answers your other question. We time-based bill. What length visit did I need to see to be able to cover my time and a dietitian's time? And it was shockingly less than you would think it would be, but I needed to be doing at least a level 3. So somewhere in the 20 to 25 minute range on follow-up visits. So all initial visits are still a lengthy visit. The follow-up visit is shorter because they spend a chunk of time with me, and then they move along to the dietitian for more intensive medical nutrition therapy with that. So currently my new patients are 60 minutes. My follow-ups are 30 minutes. And I did that for a couple of reasons. One, I have a learner with me almost every clinic session, and to teach them appropriately, I need more time in which to do that because I want them to do it. I don't want them just to watch me. They watch me initially because most of them have not seen a lifestyle medicine visit, what that looks like. And then we progress them through doing lifestyle assessments, writing lifestyle prescriptions, and then handling that visit by themselves. And what's so beautiful about that is the prescriptions that they write are probably not the prescriptions that I would have written for that person, but they were developed in collaboration with that person, and they are and they're fine. That's the deal about lifestyle medicine, is it doesn't have to be perfect, right? I might have written a prescription about nutrition and they wrote one about sleep, and that's fine because the patient gets better, and not everything has to be solved in one kind of swoop. What I tell people who don't have the luxury of a 60-minute visit or even a 30-minute visit is it is often not about how much you say. I actually don't talk a whole lot during our visits, and it's not what you say, because that's the second piece of barrier that I hear. I don't have time and I don't know what to say. I'm not a nutrition expert. I don't know what I'm supposed to say. It's about how you say it, right? 9 times out of 10, the patient is going to develop their own treatment plan, right? And it can be done in 5 minutes. So instead of saying, don't eat fruit, it has too much sugar, you say, what do you think would be helpful in getting your blood sugar under better control? And they'll say, I probably should eat more fruits and vegetables. Absolutely. You are right. When I look at all the science out there, that helps get our blood sugar under control. How are we going to do that? How are we going to make it work in your life? I could probably do canned peaches, but they're packed in syrup. Can we drain it and rinse it? Could do that. And it's done, right? So I'm blessed to have long visits, but even if you have 2 minutes with someone, you can create an actionable item for them to put into place that is meaningful for them, right? If you don't have access to a lifestyle medicine specialist or a dedicated lifestyle medicine clinic, or you don't have lengthy appointments, there's always something you can do. It's just about how you change how you talk to folks.
Right. And people love to know that they're cared for.
Oh, absolutely.
There's that.
The number of things that have been disclosed to us in lifestyle medicine that are in no way what you would consider part of lifestyle medicine, because we listen, right? We are a safe place. That's the other thing I tell people at the first visit. I'll say, okay, here's how this typically goes. I have a lot of knowledge about all of these things. And so if we talk about the science behind all of these things, I got you. I'm the expert. You are the expert on you. So I am going to listen. I'm going to pop in and ask some questions, but I just want you to tell me your story, right? Your story of what you want for yourself and what has led up until the person I'm seeing right here. And I'm going to pop in with some suggestions of things that I know from the science standpoint will work. And you tell me whether they are important or are able to be done for you right now. And if they're not able to be done right now, is it something we can fix, right? Is there a barrier that we can work on together? If not, that's okay. We work on something else. Anywhere you want to start. I actually wear a ring on my finger in clinic that says begin anywhere, because people tell me, I don't know what to do. I don't know how to start. And I'm like, anywhere you want to start is where we start, because there's no wrong answer to any of this. And the other thing I tell them is when you come for follow-up, if you have done none of the things that we talked about today, I still want you to come. And I am not going to be mad at you. I am never going to shame you. I am never going to say that you are non-compliant. I would like for you to reflect and think about what kept you from doing it, because all that means is we didn't write the correct plan. Something that was big and important in your life stood in the way of being able to do what we developed together. And so we just need to go back to the drawing board and write a better plan next time. But don't just not come. I am never mad at you.
I love that.
And I think they feel that way. They're like, you're going to be mad at me. Maybe that is not my job. It's not my job to be mad at you.
Yes, I love that. And I hear that too. But so I have a question. You mentioned that you have 60-minute initial visits, 30-minute follow-ups. How often do you see people?
Usually after their initial visit with me, they get a 2-week visit with the dietitian, and then they get a 4-week visit from me, so that they're seeing somebody every 2 weeks in the initial couple of months. So usually I follow monthly and the dietitian follows every 2 weeks. And then we partner with our integrative health team. They have psychiatrists and health psychologists and a physical therapist. And if I'm working with someone that has a lot of joint issues, I'll often put them in aquatic therapy with them. And so aquatic therapy is usually going to run 6 weeks. So if we collaboratively decided that physical activity was their goal focus, I may not see them until they finish that round of PT to refocus, knowing that physical therapist sends me that note after every session so that I sit and read what they were struggling with, and I'll pick up the phone and call them and be like, I heard you might have had a tougher session today in physical therapy. Tell me about that. How can I help you with that? Same deal with the psychologist. A lot of times we discover that the mental health piece is the bedrock that we need to build our lifestyle medicine plan on, whether it be a disordered eating, which is often not fleshed out in any other visit until they come to lifestyle medicine. And because I tend to not go, tell me about your food. I say, tell me about your day. And I was like, I want to know like when you go to work, when you eat during these periods and those kinds of things. And so then you can just pick up on patterns of wait until the end of the day and then eating 3,000 calories and then feeling guilty. And so then we're going to get them treatment for binge eating disorder or whatever it is that we feel might be going on. Usually I start with a visit with the psychiatrist to make sure we get the correct diagnosis. And that's the other thing. Mental health is not my specialty. So I want to make sure that it's not anxiety, depression, binge eating, bipolar disorder. I want the correct diagnosis so that we can incorporate that into our treatment plan.
I love that. So important. I'm going to kick it over to Deborah for a minute because she really has a nice way of framing up the whole like future of nursing and our scope of practice and things like that. So Deborah, can you take over for a minute?
There it goes. Sorry about that. Hi, thank you, Susie. And wow, I had actually been exploring we've been quoting from the Future of Nursing, and Josie, you and I were talking about both the 2010 and then the 2020, and the 2020 really was leading off of the COVID pandemic and the glaring light that was revealing the social determinants of health. And I'd love to ask you about that, but also if I can go back as an educator also, looking at the ANA, they had responded to the 2010 Future of Nursing report and some of the key messaging there about nurses practicing. They basically stressed 4 areas. Nurses practice to the full extent of their education and training. Nurses achieve higher levels of education and training through the educational system and a seamless academic progression. So that's a key. Full partners with physicians and other health professionals in redesigning, and then effective workforce planning and policy making there. So taking a look back also at 2020 and back to 2010 and where you are with all of this with some enormous experience in the nursing school, but now with this lifestyle medicine dedicated clinic. Can you share a little bit more about your nurses, how you worked with them in the past, how you would transform that given all of this that you've experienced up until this moment in time today? What you did mention the essentials and now the beautiful way that you work with those nurses coming through. One of the calls for the Future of Nursing 2020 is we want our nurses to rotate not just at the bedside in the acute care setting, we want them out in the community and experiencing that. So given that, focusing first on the education piece of all of that, can you reflect really broadly on that?
Yeah, absolutely. And starting out, when I started as a faculty member in school nursing, I was 27 years old. I was a baby nurse myself. I felt it was often like, we need the person in charge. And I was like, is that me? Am I the person in charge? But it's very much acute care focused at that time. It's how do we get all these medicines in on time? And how do we do all this wound care? And how do we get tube feedings done? And all of these different kinds of things. And that's vitally important. I think we have to start weaving into the patho that we teach students how lifestyle impacts that. How does sleep impact wound healing? And those kinds of things, so that it's still acute focused, but the threads of lifestyle are just as important as turning people every 2 hours. And why do we turn people every 2 hours? And how does lifestyle support that? How is adding in fruits and vegetables actually going to lead to better skin perfusion that is going to lead to decreased pressure ulcer development and those kinds of things? So it's really going back to the roots of what we teach and making sure that all along the therapeutics that we're discussing with people, or the nursing interventions when you're writing the famous care plan, right? What actually are we trying to accomplish, right? Because when we're turning people, we're just trying to make sure the skin is oxygenated and receiving blood flow. But how do we make good blood flow, right? It's not with a wedge pillow. It's with a fork and knife. That's how we make good blood flow. And teaching that, and not just 2 words on a slide, right? That say nutrition, right? That means nothing. I had a patient in clinic today who had a condition that I am familiar with the condition. I have not seen it in outpatient land before. So I was pulling some papers to read before clinic this morning, and I pulled the clinical practice guidelines for that. Even though I'm not adjusting any of their medicines or doing any of that kind of stuff, I wanted to see what the clinical practice guidelines had to say about nutrition and lifestyle in general. And it was 1 sentence that said nutrition and physical activity should be addressed at each visit. What about it? Because you literally told me what liver function tests to order to monitor their liver function. But what about their nutrition? Are they not supposed to have this? Or, so we don't do a good job of embedding what the actual science says, how these softer skills of medicine, right? The nutrition, the counseling, how that impacts cellular change, right? And it's not as fun to talk about all of that. I'm married to a biochemist, and when I'll talk to him about stuff, he'll be like, what cycle does that get into? And I'm like, baby, I don't know, but I'm sure you do. But this is how it translates into the clinical outcome I'm trying to accomplish. But layering that in is going to be so important. We have to empower nurses that they belong at the table when healthcare decisions are being made, right? We tend, even folks who have been nurses for a long time, we tend to see ourselves in a supporting role, right? And we are absolutely there to support our other team members, but we are not less than any other team member that is there. Right? Now, I may defer to physical therapy on the best exercise to rehab, whatever it is, right? Or to work on balance or any of these kinds of things, but we are equal in terms of our knowledge. It's just knowledge about different things, right? And when we toss away our ego a little bit, all of us, and realize that it's not about what initials are after my name. It's about what I know and what I can bring to the table in taking care of this patient. Because that's what we're here for, right? We're here for the patient. We should be here for the patient. That's what I'm here for. And that has evolved over time. I can remember not feeling like I was important enough to challenge things, right? But if you become confident in what is evidence-based, then you lead for that change, right? So if you're a bedside nurse on a cardiac floor, right, then get really comfortable with lifestyle interventions that are directly linked to better heart outcomes. And then ask for a meeting with your attendings that admit to that floor, and sit down and say, these are the outcomes when we feed people like this, right? Because they want that too, right? They want their patients to get better, right? That's how the majority of things in healthcare have occurred, right? We're like, people do better after surgery when you get them up and move them around. And so somebody somewhere met with those doctors and said, when you get your patients up out of the bed, they do better, right? They don't get as many infections. They go home sooner. We turn that bed over quicker, all of these things, right? And we just have to have those conversations now. And if they say, well, that's great, who's going to do that? You have to be ready to say, I am, right? When you open that door, you got to be ready to fill that gap. And you say, we need to be talking to our new onset diabetics about the importance of plant-based nutrition. Who's going to do that, right? Who's going to have those uncomfortable conversations with dietary, all those kinds of things. And because it does no good to tell people about it if we still serve them. And so it's not something that you're just going to wake up tomorrow and go change the world on. But the first step is your personal education and learning what it truly is about, and that the way we've been taught in terms of dietary guidelines is not quite the full picture. I remember when I first started, I was super mad about dairy. Let me tell you, I was like, oh, that's a lie. You can have dairy. That's fine. Like, dairy's super healthy. There's no problem with it. And I would read the studies and be automatically irritated as I was reading it. I was like, clearly they have pulled some things out and this is not the correct thing. And I was in Amsterdam studying for boards. And I remember reading this article and going, you gotta be kidding me. Like, all the years. And it was confounded by the fact that vegetarian diets were lumped into there. It wasn't the dairy that was making us better. It was the fruits and vegetables. Giving yourself permission to be uncomfortable with the information that you find is a bit, because I just felt mad for a little while. I was like, why did I spend all that time learning that plate if that wasn't the right plate, and all of these different kind of components there. And then once you're comfortable with it, with the knowledge that you have, put it in place for yourself. And there's plenty of research out there that shows that healthcare providers who adopt healthcare behaviors are more likely to counsel their patients about it. But I use it all the time as icebreakers with patients. When I'm going through a plate, I'll be like, so this is the protein section. Now, it could be fish or chicken or beef or beans. I'm like, I don't have any of these other than the beans. And they're like, you don't eat meat? And I'll go, I don't. And they automatically go, what do you eat? And that just breaks down the barrier. And then we start building black bean tacos. And you're much more comfortable about it when you know that it can be done. And when you know that here in Mississippi, you can eat a plant-based diet without having to order everything from some random seller somewhere, and that it's not weird. I don't use a bunch of weird products. I use the same things that everybody else uses. I just get a little bit more creative with the way I flavor things. But had I not put that into place in my life, it would be really hard to tell people that you should eat a plant-based diet, and those ways. And it trickles through at all levels of healthcare. I think really the way we start to get traction as being worthy of sitting at the table when healthcare decisions are being made is that we train together. Instead of training nurses one way and training docs another way and training PT another way, we have to train together. Because that is when we learn how valuable each one of us are. That the physician absolutely cannot do their job without the nurse, and the nurse cannot do their job without the physician, and neither one of us cannot do our job without PT, OT, respiratory, RDNs, even the nursing assistants who come and help us really do the brunt of the work for us a lot of the times. Every single one of us has a value that is added to that patient. And the patient is going to win when we're all speaking the same language. And when we train together, we speak the same language.
That's really all powerful and so beautiful. You really employ a number of things when you're implementing these changes. And one is a lightness to it, a humor. And this is so serious. We're facing literally the most expensive, and we know what ways that the numbers are going. Our healthcare costs are through the roof. The Commonwealth Fund, all the statistics in terms of our cost as compared to the top 40 other developed countries, and our outcomes, our health. And some of the other numbers about our children and the life expectancy. So we can go on about that. But in the face of all of this, we can be still meeting one another on this very human basis. And part of that is the story. You tell stories a lot. You paint a picture. And I see you doing that from your chair when you joke about your chair, and always a little nervous about this, but we can see you right there. And so it's the power of story. And that's really part of the history of nurses. Nurses are storytellers, and nurses have a long history and of story. And we have many legacy leaders from Florence Nightingale on up, and those even that preceded her, and these stories and the lightness with which we tell them, with the gravitas of the situation and what's at stake, and what we can do with such simple things like you talk about. 1 minute I'm showing the plate, and there's, no, I don't eat any of those. And then we're talking, what do you eat? And then it's bean burritos. But just the humor and the meeting people right where they are, listening, being human. And it seems that is something key as a tool and a technique that I think nurses really adopt oftentimes with their patients. We listen to our patients, but you're adopting that with all of your colleagues, with the interdisciplinary team, evoking this curiosity, trying to just get that person peeking around the door, or the other team, or what, and listening, what do you need? And you talk about being really specific and strategic. So it's hypertension. Okay, we know about hypertension. Well, what is it? So actually around the theme of the hypertension, the self-care, like I've never heard a title of an intervention in a program framed up the way that you have and listed that way, but you listened, and it's very targeted for exactly what is needed. You were going to share there a little bit and just reflect on.
Oh, yeah. What is life but a series of stories? You know, that's what we are, is a series of stories. And I have tons that have led me to where I am now. Sometimes I stop and go, what did I say yes to that has led to whatever it is I'm doing now? But that's part of my story. It's part of the reason I get up every day and come and do this. The same for our patients. And I think that the reason I appreciate that so much is the background in pediatrics. I started with these little tiny people. And as a school nurse, these 3, 4, 5, 6-year-old kids who just wanted to come to the nurse's office because I had snacks and coloring sheets and other things. And that's fine, because that usually meant that they were stressed or lonely or something that needed to be met from a social standpoint. And I would get them up in my lap and we would color together and we would talk about hopes and dreams and what they wanted to be. And they all had these amazing things. They wanted to be a basketball player, or they wanted to be a princess or an astronaut, or just random grand things that these children wanted to be. And then you fast forward to the 45, 50, 60-year-old that you're seeing in your office. They were that kid once, right? None of those kids in all the years I did pediatrics climbed up in my lap and said, you know what? I would like to have chronic kidney disease. I would like to go to dialysis 3 times a week, or I would like to take 10 cardiac medications, or I would like to be on medicines that cost half of my or more of my income that I spend on a monthly basis. And what happened between astronaut and what we're seeing now is a plethora of stories that have occurred that shape the person that you're seeing right now. And unless we are humble enough as healthcare providers to step back and go, I don't know your story, but I would love to hear it if you would like to share it with me. And not just the story that you've had, but how you would like your story to continue. What does the next chapter look like? Whether that's next week, whether that's next month, whether it's next year. And how can I help you write that, right? We may not be an astronaut, but we can bend over and tie our shoes. And those are the things that matter to people. So I don't care what somebody weighs, really and truly. I don't care what their BMI is. I care how they feel, right? How do you feel? And are you satisfied and happy with where you are in terms of your health? If not, let's fix it, right? Let's do something. But I'm always going to ask you how you feel, not what do you weigh, as it's just, you're more than that. right? You're more than what your blood pressure is, what your weight is, what your blood sugar is. The story matters.
That is so powerful. And I think that we get into these ideas of this is the science and this is the way it should be. And if someone isn't doing this, get them over here. But when you approach it that way, you're seeing these amazing outcomes. And the better someone feels, the more empowered they are. And then you get into that cycle of success. And the person gets more in touch with what they want. And they can change their vision. And all of a sudden they're imagining, maybe not the astronaut, but they're imagining, I can take that walk. I can go on that trip, right? I can cook that dish.
Exactly. I can get on the ground and play with my grandkids. And so it's not that we don't talk to people about the health consequences of whatever, right? If their BMI is over a certain amount, or their waist circumference, because I don't even like BMI, their waist circumference is over a certain amount, or their blood pressure is too high. Like, it is my ethical duty to discuss with you how that is likely going to negatively impact your heart health. But I always ask permission. Can I talk with you about why your blood pressure number concerns me a little bit? And then we have that conversation. And if they say, Josie, I'm fine with it. Like, I take my medications, I feel good, then what else can we work on? What is it that you're not satisfied with? Something, because you came to see me, right? So let's focus on that. And as we improve that area, I'll say, I'm going to circle back around to your blood pressure every time we talk. We're going to talk about it again. And that's okay, because then they come back to see me. It doesn't do any good if I just make people feel guilty about not doing things. Then they don't come back to see me and nobody wins.
Thank you. That's so beautiful. Josie, can we circle back around? And then I want to turn it back over to you, Susie, here too. Thank you for all of this time. So when we get back to how do we do this, we all want to be with you right there, right now. We all want to be there.
Come on.
I remember when I first saw you on Facebook, I think I reached out and I said, can I come and shadow with you there? And I didn't know you. I don't even know if I was with the member interest group at the time, but how do you see us? I guess another circle back to that nurse, that BSN nurse. What do you think she has the authority to say, whether or not you said educate ourselves? So she's responsible for educating herself, but what do you see her as having the authority to say after she's learned about this, took the essentials, the 5.5 at ACLM? And then how do you see us really standing this up? You're in this amazing space. How do you see this moving forward? How do we clone that? How do we move it outward and get other stakeholders involved in putting together this vision of nurses leading from the future of nursing, and then all that we know from the science of how lifestyle addresses the social determinants of health, merging all of that with what we know is on paper, this amazing essentials document. But we have faculty that are not educated with this. So how do we put almost like this Venn diagram together?
Yeah, absolutely. And man, I think if I knew the concrete answer to that, I would be retired and be a consultant. But I really think it does start with communication and talking to your fellow healthcare providers about what it is our ultimate goal is for that patient. And then you walk it back from there, right? If it is, let's say you're an inpatient nurse on a general medicine floor, right? 30-day readmissions are an important thing to be looking at in terms of hospital reimbursement and all those different kinds of things. So when we put that as a metric and we have team meetings about that, we want to integrate in what the lifestyle pieces are that are going to impact 30-day readmission rates, right? Because you have to speak the language that your healthcare system is trying to speak, right? It can't just be about it's better for the planet or it's better for the animals or any of these kinds of things. It's got to be, is it better for the health system? And I don't mean just your individual hospital, but the healthcare system, because you alluded to the fact that we cannot keep going the way that we are going in terms of our healthcare system and being able to take care of these patients and stay afloat. And so finding meaningful metrics is important. And actually, one of the things that we're going to be looking at is how we bring forth our advanced practice providers into that role. A new role that I'm going to be stepping into is the chair of the Advanced Practice Provider Council here, which will be all of our advanced practice providers, our PAs, CRNAs, and NPs. And what I've been charged to do is help create that, right? Help create these subcommittees of inpatient, outpatient, adult, peds, and then acute care services, right? And how do we make meaningful impact for our health system so that they see that APPs lead, right? That advanced practice providers lead. And that often goes into finding some quality metric that needs to be looked at, right? Whether it be 30-day readmission, whether it be throughput, right? How long are our patients staying in the hospital? How long is it taking to turn beds over? Who can be discharged? All of those different kinds of things. What kind of quality can the advanced practice provider bring to the table there in employing the fact that we are trained to think about what happens outside of the hospital? And we are trained to think about what our patients are going to need in terms of where they're going to get their medications and how far away do they live that they have to drive for these things, and start to apply the things that we do already into measurable improvements for a health system. And I think that's the perfect place to add in lifestyle strategies as well, and especially social determinants and how we address all of those things so that it's a no-brainer when you want to develop something in the health system. You're like, I got to have an APP because they know what they're doing, right?
Thank you for that. That is excellent. We are so excited to hear about that, and we'll want to continue to follow that with you. So it's about, again, getting specific. What are the numbers? What, again and again, we hear, what do they need? What does someone need? Whether it be the patient, the healthcare system, and how do we measure it? And being very specific, strategic, we have to be thinking that way. Can you speak briefly to the reimbursement, and just as a follow-up to that, how do you see us being able to have a nurse, even we talk about the LPN all the way up to bachelor prepared on?
When you start to look at reimbursement for folks who don't carry billing numbers, right? So it's much easier to think about how do we build the case for advanced practice providers to do this, right? And I actually think advanced practice providers are perfectly positioned to be the leaders of lifestyle medicine simply on a return on investment, right? Any way you want to slice it, we cost less to provide services. And it is a perfect break even when you look at what you get back for these types of services. And what becomes trickier, again, are the service lines that don't traditionally carry a reimbursement associated with it, right? Like your nurses, even RDNs to a certain amount. And that's a touchy subject, but they can bill. Unfortunately, their reimbursement is far below what they are worth, and is very frustrating because they are the champions of this team and don't get paid to do it very well. But we have to continue to show that they are important members of the healthcare team. And the same goes for registered nurses, LPNs, medical assistants. Our medical assistant, we had her trained at, and she wanted to, I didn't just tell her, trained as a diabetes prevention program coach. And so she sees patients for that reason and gets paid to do it. So looking at these kind of alternative reimbursement models that can do that for you. So DPP does not have to be a clinician, so to speak, to do that. And then looking at tracking your outcomes and converting that to a cost saving, which is a harder sell in especially in large centers, but harnessing onto that piece of, think about joints and how much a joint infection costs an institution, right? Whereas how inexpensive it would be to bundle that payment and have a class led by a registered nurse in modifiable risk factors. So that doesn't have to be delivered by me, right? That could be delivered by a registered nurse. There is not currently in existence a reimbursement model for that. but build it, right? I refuse to take no for an answer. I just keep asking different people until I get the answer that I want or until I don't work here anymore. Like I just keep asking and it eventually works out. And so is renegotiating contracts with payers easy to do? No. Is it what may have to happen? Yes. And so can we work with a small subset of patients in a certain payer group and prove that we can make them better and prove that we can cost save and then take that information to whoever negotiates contracts for your institution and say, look, our Medicaid patients that participated in this program had this % less joint infection, and that saved the medical center this amount of money, and it saved the insurer this amount of money because they paid for all of this stuff. And you could have paid me $100 for this nurse to do this class. And so I think what we try and do in healthcare is make what we're trying to do fit within current existing models. And if healthcare has shown us anything, it is the current existing model does not work. So we got to try something else. And that just like leaving a school of nursing and moving to a school of medicine was scary and hard. That's scary and hard. But if we want to change the future of healthcare, we have to do scary things, and we have to be willing for it not to work the first couple of times that we do it, right? We didn't start out time-based billing. We started out medical decision-making billing and doing those kinds of things, and it was abysmal. I felt like everything was a level 4. I was like, look how much time I spent, and I'm exhausted, and I've done all these things, and then compliance would come back and be like, that was a level 2. And so we had to go back to the drawing board and figure out what worked. And we continuously look at that. I just redid all of our templates in clinic. And what I did was I pulled numbers for what RVUs are associated with each level of visit, what I could get keeping my visits at 30 minutes. Because during COVID, all of my visits were 30-minute visits because they were mostly telehealth. And so I said, this is how many patients I can see at 30 minutes and how much money I bring in for that. If I expanded my new patient visits to 60 minutes, this is how much money I could do it. And guess what? It was the same by $4 or something. And you're clearly going to get better patient outcomes. So you always have to have the data. If there is something that you're wanting to do, it can't just be because you think it's a good idea. Like you have to go with the numbers, whether that be biometric improvement of things or whether that be cost savings of things or break evens of things. Everything I've wanted to do in lifestyle, I prove it on paper first. When I wanted to add a dietitian, I was like, this is what we have to do. And it's completely doable to break even, right? When I want to add an exercise physiologist, again, another group of wonderful healthcare providers who do not have a stable reimbursement model outside of cardiac rehab. This is how many patients I'm going to have to see, and this exercise physiologist is going to have to see to make this fiscally viable. And by fiscally viable, what we are comfortable with is we don't cost money. Like I'm not trying to make billions of dollars. I'm just trying to keep coming to work. So I say I like to fly underneath the radar. Nobody needs to be looking at my billing. I'm just neutral, and I am here for whatever speaking engagements or whenever a press release needs to happen about something related to nutrition. That's when I get called, not to the compliance chair.
Yes, Josie, you've spent so much time with us. We really appreciate all of your wisdom. It has been so wonderful. What I have heard from you is that you are growth-minded, which I think we all need to be, because if you're not uncomfortable, you're not growing, right?
Right.
And that you have this grit and determination and persistence to just
My husband would call it stubborn.
Whatever it takes, right? Hey, whatever it takes. So we appreciate you doing all of this and leading the way for not only nurses, but the whole rest of the team. It really is seriously important work. And it's informing what the rest of us are able to do as well. So I do appreciate that. I know we've talked about so much. Is there anything else that you want to share with any of the nurses listening?
Have fun. This is a hard job. Like, it is, healthcare in general is a hard job. Being a nurse is often thankless, right? Often relatively gross, right? And you have to love it. And part of loving it is having fun. And for me, thinking about new ways to help people is fun. Like, I get excited and thinking about how can we do a cooking class for something, or how can I get my patients in my clinic exercising? That's fun. And so whenever you look for the fun in it, like, you don't burn out when it's fun. It's hard always, but as long as it's fun and you continue to have fun in your exam rooms, at the bedside, wherever, because it's such a vulnerable point of time for that person that you're with, right? And just being real, being open, being honest, and laughing with them when appropriate is so good for the soul, for the person and for the nurse. And so I think if we just always look to love people and serve them to the best of our abilities and have some fun while we're doing it, it works out in the end. Even though you think it's not going to work out, it works out in the end.
Yes, I appreciate that so much. And thank you again. I am going to wrap it up so that we can get on with our day. But thank you so much, Dr. Bidewell, for being with us and sharing all this knowledge.
My absolute pleasure.
It's beautiful.
Yes, thank you so much. And yes, Dr. Josie Bidewell, this has been amazing. If I can ask one quick follow-up before we go, because you said we might have 2 hours, and I know we're going long, but I just want to see, may I ask you, Dr. Bidewell, to just paint a picture for a minute, tell the story of your nurses, one or two stories of your nurses with the patients in their interactions and what they're doing.
What I see is what my fellow practitioner, my nurse practitioner, gets to share with me. And she often celebrates her wins. And one of the wins that we recently had was someone who has not been able to be on the transplant list and has been tied to a dialysis machine for years and years, 3 days a week. And to see the gratitude in that person's eyes on the fact that they are going to get a whole new organ, right? Like a whole new organ after years and years of trying random things, right? And not having a person that listens, because she's trained as a GI nurse practitioner, right? Has been doing lifestyle medicine for 2.5 years, right? Just listening to what this person said mattered to them and what kept them from being able to do it, right? And then meeting them right where they are and putting, and I'm not going to say easy to do because none of it's easy, right? But relatively what we would consider easy bits of changes to be made. And this person's going to get a new kidney. And to watch how satisfied she feels as a provider in being able to do that, right? How often do you get to do that? In general medicine, do you get to feel like you saved somebody's life today? And really the person saved themselves, right? We have very little to do with it, right? We just support and coach. But that's what keeps you going on the days that it's hard. And that's when it's hard for me, when I get tired of thinking about how do I grow lifestyle medicine? How do I continue to reach out to all the different schools and try and get this embedded into curriculums here and precept all these people? It's because I'm going to retire one day, right? But the skills that we teach nurses, I get to celebrate these wins forever, right? Because I taught her, she'll practice longer than me. She's a newer practitioner. She's going to teach other people to do it, right? And that way, the feeling that I get when people get better, it never goes away, because I know as long as lifestyle medicine stands, somebody is getting a new kidney. Somebody's getting a new heart or a new kidney or coming off of something. And that is the best thing that you can experience as a healthcare provider.
I will wrap it up there. And thank you again, Dr. Bidewell, for being with us, sharing all this information. There's a lot here to take apart, to digest, and to help people move forward. So thank you so much for this.